This week on the BackTable Podcast.
This is metastatic pancreatic cancer. This is not a curable disease. We're looking at survival improvements in months, not in years, traditionally. So you've got to think about the quality of life of the patients also. They shouldn't have a terrible time in that time they're living. And frankly, they should be living. They should be going out, doing the activities of daily living. If they stay in New Orleans, attend some of the festivals that I think you guys have every weekend.
That's right.
I hope to attend some of them. So I think it's important in that to really look at what the patients want, what the quality of life is, and what are we really doing for the patients. That's really important.
Welcome to BackTable Podcast. This is part 1 of a 3-episode series we're going to be doing on pancreatic cancer. Today's discussion is going to be based on the evolving landscape of systemic therapy for advanced pancreatic cancer. My name is Jon Mizrahi. I'm a GI Medical Oncologist at Ochsner MD Anderson Cancer Center in New Orleans, Louisiana. I am very pleased to have a special guest on our podcast today. I know him well, but I'll allow him to introduce himself. Dr. Pant.
Yeah, thank you, Jonathan. It's truly an honor to be on this podcast. I'm Shubham Pant. I'm a professor of GI Medical Oncology and Phase 1 Therapeutics at MD Anderson Cancer Center in Houston, Texas.
So I'll make a note here. Shubham was one of my clinical research mentors at MD Anderson. So I will tell you that if I say anything wrong about pancreatic cancer, I only have him to blame. But he taught me everything I know.
That's true.
Don't tell Bob Wolf that. To set the stage of our discussion, we're going to be talking about advanced pancreatic cancer. I mean, I think this goes without saying that pancreatic cancer is really a menacing malignancy. It's one of the most challenging cancers to treat. Obviously, both of us are biased in that, but I do think our colleagues would agree. The headways we've seen in other malignancies, particularly in the GI cancer space, we just haven't seen really in pancreatic cancer. We think we're cracking that nut, and we'll get into some of those novel therapies, and hopefully that landscape is shifting. So in our first discussion, this first episode, we'll be discussing systemic therapy for advanced disease. We'll have other discussions in future episodes about multimodality and multidisciplinary management of patients with localized disease and future directions for pancreatic cancer. But just starting off very basically, Shubham, how do you approach what our options are? What's the current landscape for first-line therapy for patients with advanced metastatic pancreatic cancer?
Yeah, John, thank you for that question. You're right. It is a vexing problem for us. So metastatic pancreatic cancer would be stage 4 pancreatic cancer. So patients present with a pancreatic mass and they present with metastases. That means it's gone to either liver, lung, peritoneum, different places in the body. And you're right. I mean, we have treatment options, though we need to do better. So let's say a patient presents with stage 4 pancreatic cancer. First, we look at their ECOG. So if it's ECOG 0 or 1, that means they're fairly active, are able to do their activities of daily living. Then we think about giving them combination chemotherapy. And there are kind of 3 options out there. So there is a FOLFIRINOX, which is 5-fluorouracil oxaliplatin and irinotecan. There is NALIRIFOX, in which irinotecan has been replaced by liposomal irinotecan. And then there is gemcitabine and Abraxane, which are 2 drugs which are also used for the frontline treatment. Now, the way these trials were done were that gemcitabine Abraxane was compared to gemcitabine, and there was an improvement in survival of about 2 months approximately. Then you had FOLFIRINOX versus gemcitabine, and the median overall survival of FOLFIRINOX was about 11.1 months. And then we had NALIRIFOX, which was a global trial versus Gem-Abraxane, and the triplet won over the doublet by about 2 months again of overall survival approximately. So if the patient honestly is super fit, folks tend to use FOLFIRINOX or NALIRIFOX. If the patient is kind of ECOG 1-ish, I would say, 2, then folks tend to use gemcitabine and Abraxane. The other difference is that the FOLFIRINOX is given, or the NALIRIFOX is given once every 2 weeks, IV. Gemcitabine Abraxane is given weekly, 3 weeks on, 1 week off. We also have different dosing schedules, which is every other week, but those are based on more retrospective reviews rather than prospective trials. The other thing with FOLFIRINOX is, or NALIRIFOX, that patients need to wear a pump of 5-fluorouracil for 48 hours, so they need a port. And they get this chemo every 2 months. So that's what we kind of tend to use in a way. So if they could either get a triplet or a doublet based on, honestly, on ECOG, on some comorbidities, and mostly physician preference.
Yeah, I think that's a great overview. And when I was training, which despite how I look wasn't that long ago, I would regularly have the conversation with FOLFIRINOX or Gemabraxane, right? NALIRIFOX wasn't quite on the scene yet. And the general consensus, even though we didn't have those head-to-head trials of Gemabraxane versus FOLFIRINOX, that FOLFIRINOX was a more active regimen, right? The triplet we thought was more efficacious than the doublet, though they had never been compared head-to-head. So historically, what we had done is just for your fittest patients, we would say, all right, FOLFIRINOX is kind of the optimal choice for you. So I think there's some things that play into that, though. And I've found that now we have NALIRIFOX too, that in terms of who's the right FOLFIRINOX candidate, who's the right Gemabraxane, who's the right NALIRIFOX is a very blurry line, right? It's not always so clear. So I don't know what your practice is. I mean, I'll briefly say kind of what my approach has been is that I often, engage with the patient, just say, hey, look, if they're 50 years old and have an ECOG performance status of 0, I think to me that's pretty straightforward that we're using a triplet. But for my patients who are kind of pushing 70 but still pretty fit, I have the conversation like, hey, we have these regimens, one or two, FOLFIRINOX and NALIRIFOX are a little bit more efficacious in terms of survival, response rates too, versus Gemabraxane, but it's not a dramatic difference in survival. And I would say on average, Gemabraxane tends to be more easily tolerable, especially if you're doing the once every 14-day dosing. So that's kind of how I talk about it with them and ultimately come up with a group decision. I don't know what your take is, or if you're like, this is what I recommend and take it or leave it.
Yeah, no, that's exactly. So I talk to the patients about what they would want to do. That's important, because FOLFIRINOX, the patients, so it's interestingly, FOLFIRINOX, the patients on NALIRIFOX, they feel it a little bit more. That means they get more diarrhea, fatigue, so they feel it, and nausea. Whereas gemcitabine and Abraxane patients necessarily don't feel it, but their counts show it. So if you're giving weekly, 3 weeks on, 1 week off, folks think FOLFIRINOX or NALIRIFOX is tougher than Gemabraxane. I would counter that. I think Gemabraxane could be tougher because of neutropenia, thrombocytopenia, and a lot of times we have to dose adjust, drop one of the doses day 8 or day 15, and then go to every other week dosing. So traditionally, if you give Gemabraxane, that's fairly toxic, especially of the hematological toxicities. The other interesting thing I think our listeners should know is that NALIRIFOX utilizes 60 milligram per meter square of oxaliplatin, whereas FOLFIRINOX utilizes 85 milligram per meter square of oxaliplatin. And why that's important is because patients get neuropathy. So with FOLFIRINOX, it's not if, it's when they're going to get the neuropathy. And they start kind of feeling it, and it gets to, a crescendo by about, we say about 6 months of therapy, though in some it can be earlier, some it can be later, but sooner or later the oxaliplatin neuropathy catches up. Now in NALIRIFOX, interestingly, when they did the analysis, the neuropathy was 50% less than Gemabraxane. So Gemabraxane grade 3 neuropathy was 6%, NALIRIFOX was 3%. So that's something to consider, that if long-term I'm going to carry on these patients, or if they're diabetic or something, then I would think about using NALIRIFOX because of the neuropathy. I think that is fairly significant because it is a quality of life for our patients. Although with NALIRIFOX, then you can get a little bit more diarrhea, maybe potentially than with FOLFIRINOX because it's liposomal irinotecan. So there are trade-offs in both regimens. But you're right. If you're fit, young, mostly you get a triplet. If you're kind of a little bit, which most of our patients are frankly older, in their 70s, mid to late 70s, then Gemabraxane, especially given every other week, I think it's a very tolerable regimen. And we do see responses and long-term disease control in these patients.
Do you ever use the 3 weeks on, 1 week off of Gemabraxane, or are you exclusively a every other week user?
I'm a little bit of both. Okay. Clinical trials, obviously, it's 3 weeks on, 1 week off. For metastatic disease, I normally am an every other week, especially when you have somebody in your late 70s, because, we did the research out here. We looked at a retrospective data set and we did not find any differences. But again, that's retrospective. Mayo Clinic also did a retrospective data set similarly for every other week. So I think, and again, this is metastatic pancreatic cancer. This is not a curable disease. We're looking at survival improvements in months, not in years, traditionally. So you've got to think about the quality of life of the patients also. They shouldn't have a terrible time in that time they're living. And frankly, they should be living. They should be going out, doing the activities of daily living. If they stay in New Orleans, attend some of the festivals that I think you guys have every weekend.
That's right.
I hope to attend some of them. So I always find that fascinating about New Orleans is just people do tend to take their leisure time very seriously, which they should. So I think it's important in that to really look at what the patients want, what the quality of life is, and what are we really doing for the patients. That's really important.
Yeah, I totally agree. I mean, we are closed on Mardi Gras, right? But I was going to say the time toxicity is a thing too. So you mentioned just the cumulative physical toxicities of chemotherapy, but when you think of someone being weekly, 3 weeks in a row out of every 4 weeks of the month, I mean, that's a lot of time to be spending at an infusion center. And you think about patients kind of living their lives. And if you're saying, hey, the average or the median survival is going to be a little bit less than a month, it's hard to argue that they should be spending that much time in the infusion center. So I think that's a point well taken. What about second line therapy? So just, take an example of a patient who starts with NALIRIFOX or FOLFIRINOX. What are you generally looking at for second line therapy?
Yeah, so it's, we unfortunately don't have great regimens. The one that is approved is the 5-FU liposomal irinotecan called, NALIRI regimen. It was based on a trial called NAPOLI-1. And, it showed a response rate of about 16%, progression-free survival of like 3.1 months, overall survival 5 to 6 months. So we have an approved regimen. The way I think most folks treat is if they get frontline gemabraxane, second line they give either FOLFOX, FOLFIRI, or NALIRI. If you receive FOLFIRINOX or some kind of, way, shape, or form of NALIRIFOX, then you get either gemcitabine or gemabraxane. And then I really give gemabraxane, every other week, because weekly regimen is only for, was approved in frontline. So we really don't know the efficacy in second line. Really, I would say only about 60% patients, 70%, in our practice, maybe a little bit more, but I would say if you go out in the US, it's about maybe 40 to 60% patients get second line therapy because unfortunately the performance status goes down so much that they're not able to get further therapy. And that time we talk about supportive care, palliative care measures, which are appropriate too. So it just has to be the right patient. That means they're the ones who are still maintaining the ECOG and they're still functional. And, those are the patients that we really can give the second line therapy to. But, you really have to pick and choose those patients and have a discussion with them about second line therapy. But normally, if it's 5-FU based overall, we give gemcitabine based second line. If it is gemcitabine based front line, we give some kind of 5-FU based therapy second line.
Yeah, another mentor of mine, Bob Wolf, used to tell me, John, it's not rocket science treating pancreatic cancer. Unfortunately, that's remain true. But again, I hope it becomes rocket science too, and we have more options. But I think that's exactly my approach. Let me shift gears a little bit and talk through some molecular profiling. So you see a new patient with stage 4 pancreas cancer. How are you doing molecular profiling? Are you doing tissue? Are you doing blood? Are you doing both? And at what point in their cancer journey are you doing that?
Yeah, so I think pancreatic cancer, though, I've led certain sessions with community docs in which they say, I did that NGS, didn't help me at all. So, which has been true, honestly, for a long time. But however, I think the tide is changing. So if you have a patient who's a younger patient with pancreatic cancer, and that we define as approximately less than 50 years of age, then you definitely should do NGS testing, next-gen sequencing, because in those patients, normally KRAS wild type is about 5% of the patient population, but it could be 5 to 10%. But in less than 50, it could be as high as 20% could be KRAS wild type. And why that's important is because 40% of KRAS wild type patients can have targetable alterations, which could be RET fusions, NRG1 fusions, NTRK fusions. You could even get MSI high disease, just different. But most of these fusions you see only in KRAS wild type patients, FGFR2 fusions. So you can get all these, BRAF V600E. So you can get all these different kind of, because why it's important is if you find them, then there are, FDA approved treatments based on basket trials for them. And patients can get durable responses with some of these agents which are out there. So I think my philosophy is if you don't test, you won't find. So it's as simple as that. You know what I'm saying? So I tend to test my patients. The ones that I think are eligible for getting therapy, I test them up front. So I test their tumor tissue. I know folks keep on talking about ctDNA. We should do this. But I still believe in the tumor tissue. I think we can get a broader range of genes with that, mutations, fusions. A lot of our tests can give us some RNA-seq, which is important for our fusions. So I think I normally like to do tissue testing. If for whatever reason I cannot get enough tissue, then I do ctDNA testing. So it's important. But if I get a KRAS wild-type patients, I do sequence them, definitely do an RNA sequence on those patients, because I just don't want to do a limited DNA sequence and then miss out that fusion. So I think my philosophy is if you don't test, you won't find. So I think you should test and especially if you're planning on giving them systemic therapy. Now, we have about 10 to 15% of our patients who come in right through the door, have have jaundice, high bilirubin, a lot of pain, a lot of disease, and we know those patients are not going to do well with systemic therapy. So the patients who are not going to do systemic therapy at all, not do well, then maybe those ones I don't tend to test, depending on if they're just going directly to hospice because of they're so debilitated, the cancer is so aggressive, then maybe those ones I might not do it. But honestly, I try to do it in almost all my patients if I can.
Yeah, I think that's a great point. And we're the same way. We have recently instituted reflex, actually NGS testing from our pathology department. So basically the pathologist looks and says, hey, this is adenocarcinoma and it's stage 4, no matter what malignancy it is. They'll actually go ahead and do NGS running panel on the patient. So sometimes I'll have that cooking for a week before they see me, and it kind of gets the ball rolling. You're right. The point you made earlier is that the rate of actionable alterations at this point, given the proof therapies we have, is relatively low. Hopefully, again, that's changing, as we'll get into in a minute here. But let's touch upon a couple of the ones that are approved. So you mentioned NRG1 fusion. So we know that the rates of those is probably less than 1% is kind of usually
less than 1%. Yeah.
Yeah, but there is an approval of zenocutuzumab, and that's a drug that's been approved for pancreas and non-small cell lung cancer for that rare fusion. And then there are you mentioned RET and NTRK, and those also have some tumor agnostic approvals as well. But one mutation I want to pay attention to for a second is KRAS G12C, right? So that's a story that was written initially in non-small cell lung cancer, where it's more common, and colorectal cancer, it's maybe less than 5% of patients with metastatic colorectal cancer have KRAS G12C mutations. But we see it in between probably 1% and 2% of patients with pancreatic cancer. So talk to me a little bit about what therapies we have to potentially offer those patients.
Yeah, so before that, John, one of the things I think which we also missed talking about, which I want to highlight, is that we also need, for all our patients, we definitely want to do germline testing for BRCA1 and 2, because first of all, it's not only that olaparib, but drug is approved in the maintenance setting. That means after 4 months of platinum therapy, but that we should be giving these patients platinum therapy, either FOLFIRINOX, nalirifol, or I'm actually liking gemcitabine cisplatin, because I think the response rates in those patients are higher. It's 60 to 70%, just about double the response rate we get for non-BRCA patients. So that's very important. So I would check patients for germline, BRCA1 and 2. That's important because we have targeted therapy for that. And not only the target therapy, I think it tells us that we should be using platinum, some kind of platinum agents in these patients. So that's really important. Now, coming to your KRAS G12C, as in Charlie, you're right. It's about 1 to 2% of pancreatic cancer. It's a little bit higher in lung cancer and colorectal cancer. So there are different drugs which are part of the NCCN guidelines. So there's a drug called sotorasib, which is part of the NCCN guidelines, and adagrasib, which is part of the NCCN guidelines. And adagrasib, interestingly, we did the trial at MD Anderson, and the adagrasib, showed a response rate of 30% plus, about 31% patients, and they did have a good progression-free survival on that. So, and it's NCCN approved, so you can get that drug. So I would definitely, not all RAS mutations are alike. So when you see KRAS, just don't put the report on the side, because if you have KRAS G12C, there is a drug that you can actually use, which is part of the NCCN guidelines, and we have data in that. And we did this basket trial called Crystal 1, and that really showed us that this drug was efficacious in the small subset of disease, and hence it's part of the NCCN guidelines.
What other biomarkers are you kind of looking at, without getting into too much detail, any that you're checking routinely? So for example, we're seeing, we know in first-line gastroesophageal cancer, Claudin 18.2 is an emerging target and actually now has an approved monoclonal antibody, zolbetuximab. There is a ongoing work into looking at for pancreas cancer. Is that something you're routinely checking, or only for clinical trial purposes, or any other biomarkers like that you're looking at?
Yeah, great question, John. So what I do is we definitely do the next generation sequencing. So in that, talking about KRAS, I think coming through, that's the most important. So we do MSI testing through, we do through NGS, but we also do it through IHC, because again, you can find that in less than 1% of patients. They tend to get a good response to the checkpoint inhibitors. And then I think one of the things on the next-gen sequencing is also MTAP deletion. There are a number of clinical trials for this MTAP deletion and frontline trials which have been launched for that. Now, coming to Claudin, We are testing it, but more for clinical trials. So the trial you're talking about, which was being tested, zolbetuximab was being tested in pancreatic cancer. The press release came out a couple of weeks ago. That's actually a negative trial. So unfortunately, that's not going to move forward. However, I think in pancreatic cancer, we have these antibody drug conjugates, a slew of them, which are coming through in as testing in gastric cancer, other cancers. And I think pancreatic cancer is definitely a target for these ADCs. So we may see the landscape change right now. But we normally do next-gen sequencing and then MSI testing, IHC, and then Claudin for clinical trials.
Great. Yeah, and I think it is disappointing to see that Claudin 18.2, at least with zolbetuximab, was unsuccessful. But you're right. Hopefully, with these kind of novel drugs, ADCs being one of them, we might move the needle there. One place where we haven't had much success is immunotherapy. So immune checkpoint inhibitors, by and large, have really not been successful in pancreas cancer, with the rare exception being patients who are microsatellite instability high, which, as you mentioned, is only about 1% of patients. So without getting into too much detail, but I know you have a lot of thoughts probably on the vaccine approach. So this is an area that's not really made it into success in the stage 4 setting, but since I know you have a big clinical research interest in this in the earlier stage setting, maybe you want to give just a brief 1 to 2 minute background on how we're looking at immunotherapy, specifically vaccine therapy in the earlier stage setting in pancreas cancer.
So John, one of the most common questions I get, I'm sure you get it from patients, is why not immunotherapy? And I have to explain to them that this is a immune desert. Pancreatic cancer is like, the way the analogy I use, it's like a chocolate chip cookie. I got it from one of my colleagues, Anirban Maitra, who's a pathologist here. And those, all the dough is all the microenvironment, and those little chocolate chips are the tumor cells. So it's hard to get through it, right? And so now you're going to look at a chocolate chip cookie very differently, maybe switch to donuts, right?
Yeah.
I'm not saying you should eat either, but that's the trouble. It's a very harsh microenvironment. And we've tried multiple immunotherapeutic approaches. They really have not worked, unfortunately. But really, I think where things can work is, so let's say patients who come in with the 20 to 25% patients have resectable pancreatic cancer at the onset, at diagnosis. That means they have a tumor sitting without, which are not touching the blood vessels. They either get neoadjuvant therapy, that means chemo before resection, or they get resection and chemo after that. But even with that, there's a 50 to 70% chance of this cancer coming back. This is a truly tough disease. It's a highly systemic disease. So what we're trying to do is give cancer-directed vaccines or immunotherapy approaches which can maybe make your immune system, galvanize your immune system, and it can actually, attack those little micrometastatic disease. So before the chocolate chips form that little doughy structure around them, maybe we can nip them in the bud. And that's important. And we've done a couple of studies, and we're doing more studies which are showing some early signals, and we're hopeful, but we just finished a phase 2 randomized trial, and we'll look at what the result will be. But that's an approach we're using in different settings. So I'm hoping one of them will pan out, because that's truly really curing the patients, right? Because with stage 4, yes, we're giving them 2 months, 3 months, maybe something. But if we can really move the needle in this, we're truly curing patients. So I'm really excited about this approach for our patients.
Yeah, absolutely. And we've had the opportunity to be involved in that trial and eagerly awaiting some of the results and then kind of what happens next with that. And, there are multiple different approaches to the vaccine strategy, right? There's the targeting KRAS as the antigen, trying to train the immune system against. And there's also the personalized vaccine approach that was kind of done more in New York, but certainly an exciting area. Transitioning to what I think is probably the most hopeful in the near term of opening the door to targeted therapy is targeting KRAS more broadly, right? So where are we with that? I mean, I think for a long time, the KRAS gene and protein that encodes basically was considered undruggable, right? It was something that was constitutively turned on in 90+% of pancreatic cancer, and we just didn't know how to attack it. And it's not unique to pancreatic cancer, but it's most common there. So that tide seems to be turning, right? So talk to me about where we are with targeting KRAS, not just G12C.
Yeah, I never thought you would come to that question. It's the most exciting part of the discussion, at least for me. So as you said, that KRAS is in 90% of patients with pancreatic cancer. I think it's a true Achilles heel of the tumor. So I've always, it was always called undruggable. But with newer approaches, we have seen that they can be drugged. Now there are a slew 10 plus agents which are targeting RAS, called Pan-RAS inhibitors, all RAS, We talked about KRAS G12C inhibitors, which is 1 to 2%. And then we also have KRAS G12D inhibitors, which is D like Delta, which are about 40% of patients with pancreatic cancer. So a lot of excitement in this area. And what we've seen is in early with a Pan-RAS inhibitor called daraxonrasib, very dramatic name, if I may say so. Reminds me of Dungeons and Dragons or something, but daraxonrasib is a RAS-on inhibitor. So this is a really cool compound in which we have a cellular chaperone in our body called cyclophilin A. And it binds to this RAS, it kind of binds and forms this tri-complex, which leads to steric hindrance. That means downstream, impacts are blocked essentially of this. So it's very, very interesting. It's called, so we always used to try to stop RAS in the RAS off. But this is a really interesting compound which blocks the RAS and the RAS on, and it basically switches it off essentially and leads to cellular death. And at least in phase 1 trials, we have seen, and in expansion cohorts, we have seen patients get longer progression-free survival and overall survival than some of the historical controls. And we recently finished a trial called Resolute 302, which is a trial of RMC-6236, also called daraxonrasib, versus standard of care chemotherapy, investigator's choice, in second-line patients with second-line pancreatic cancer. That means after front-line. So the trial is near accrual, and we hope to have the readout by next year. So hopefully, fingers crossed, we have a new agent for patients with pancreatic cancer.
Yeah, that's a great overview. And I want to kind of mention that one of the things that I think the FDA has kind of put that on a potential fast track. I might be using the wrong terminology here, but if it does show the positive data that we're hoping that it'll show, that maybe that can come to commercial market use sooner than, the typical approval process. I think I was reading that they said once the company applies for FDA approval, if it is possible, to try to get a decision within a month or two, which is faster than the normal progress, knowing that there's an unmet need in pancreatic cancer for treatment with KRAS mutations.
Yeah, the main thing is because it's such an unmet need. That's the thing.
Yeah. So next I want to move into a little bit about supportive care, right? So you mentioned at the beginning that there is a decent chunk of our patients, unfortunately, that come in who are very symptomatic. Okay, so we know that one of the biggest issues with pancreatic cancer is pain. You and I were involved in a paper talking about pancreatic cancer pain. It's not the only symptom, but it's one of the biggest ones. The other huge one is malnutrition, cachexia. Okay, so these are problems that we know affect patients' quality of life. It can affect their ability to get systemic therapy. It can affect their survival. And these are things that we can't avoid in our clinic. So when we're seeing our patients, we truly have to put multiple hats on, not just as a medical oncologist, but also as a supportive care, palliative care doctor. So what's your relationship? I know at MD Anderson, you kind of use a program called supportive care. At a lot of other institutions called palliative care, but same concept. So how do you work with them? At what cadence are they seeing patients? Are they seeing them pretty early on in disease course? And just talk me through your interactions with kind of that program.
I think that's the most important thing because, one is we are improving the quantity of life, but our patients are very symptomatic, as you said, in pancreatic cancer, and we really need to focus on quality of life. So I'll tell you, John, it's interesting. We talk about chemo, we talk about all these targeted agents. But, recently one of my patients, whose wife was my patient for maybe about 1.5 years, 2 years, unfortunately, she passed away. He wrote me a note saying, thank you so much. And interestingly, he had seen one of our APPs as an intake visit. So our PAs sometimes see patients as an intake visit to get them into the system a little bit faster. And she had prescribed them pancreatic enzymes. And this patient had gone everywhere, multiple cancer centers. And he said that one thing changed her life. More than chemo, more than anything. She had less pain. She started digesting her food, no diarrhea, abdominal cramping, all GI trouble. So her quality of life dramatically improved on pancreatic enzymes. So I think that's a very critical factor that physicians who see patients with pancreatic cancer in the clinic, who don't see a lot of patients with pancreatic cancer, maybe 2 or 3 a year, think about pancreatic enzymes because that might change your patient's life. And the way to give these enzymes is now we think we should give it with food. So you take the first one with your bite of food, and then you kind of keep on taking them throughout your meal. But if you're unable to remember that, just take all of them with your first bite of food, right? So it kind of makes it a little bit more easier. But that can be life-changing for patients. So pancreatic enzymes, if there's one thing that folks want to take away from this talk is pancreatic enzymes. Now for pain, I think, Pancreatic cancer is a weird disease. I tell my patients that, it's one of the diseases in which sometimes chemotherapy makes you feel better. Because when we give chemotherapy, they start eating better, their quality of life improves, the pain gets lesser. So it's actually one of those weird cancers in which their performance status can actually improve when they're getting chemotherapy. So that's an important point. But for pain control, it's very important. I think getting a C-leg block, if they're having a lot of pain, they present with back pain or abdominal pain, and sometimes that can be effective. So many sending to a pain management physician. And I do think palliative care / supportive care should be incorporated very early in the treatment cycle because it's very, very important. So I think for appetite, pain, just nutrition, general nutrition, all this is very important. Then pancreatic cancer also, makes you break down your muscle mass. That's very important. So nutrition is very important. I tell my patients, if they can, they should at least try to get out and walk 30 minutes every day, just some kind of activity to get their body moving. That's very important. So I think those things, and then maybe if they can do a little bit of light exercise with bands if they feel like it, I think that really helps with resistance training, with keeping that muscle mass on. So I think that's very important in patient with pancreatic cancer. And interestingly, at MD Anderson, we have a program called prehab, in which folks do rehab after surgery, but we actually prehab patients before surgery, and we've shown that can decrease the morbidity after surgery, because pancreatic cancer, Whipple surgery is a pretty big surgery. Patients do get debilitated after that, but prehabbing them and getting them ready can actually lead to better outcomes. So palliative care / supportive care, very important in the care of pancreatic cancer patient.
Yeah, that's excellent. I think palliative care is so important, and I think how you explain what their role is in cancer care is vital too. I mean, there have been studies primarily in non-small cell lung cancer that show that actually early intervention with palliative care can improve survival, right? So to me, when I offer it to patients, I say, hey, look, it's like you have another doctor whose sole purpose is to try to make you feel better. And, I guess there's the time it takes to see them, but beyond that, I mean, they're just there to work on your symptoms and your quality of life. And to me, there can't be anything more important than that, other than, of course, chemo. But, that's my bias. But so early palliative care, I totally agree. And I'm glad you mentioned the pancreatic enzyme. So that is one of the first things I do when I talk to patients. Sometimes it's very straightforward. Someone has that abdominal bloating and cramping after they eat, and they have loose and greasy stools, and you're like, okay, this is an obvious case. Sometimes it's a little bit more subtle, right? It's pain, but it's not really classic for what you might expect. So I have a very low threshold. I don't know about you. I have a very low threshold to try pancreatic enzymes. And instead of, sometimes I'll get a fecal elastase and kind of do a more diagnostic workup, but oftentimes I'll just try it. And if it's a therapeutic trial, and if it helps, we stay on it, and they do have improved quality of life. I don't know, do you usually do any formal diagnostic testings, or you just kind of, if it sounds like pancreatic insufficiency, you go ahead and treat them empirically?
Yeah, I go ahead and treat them empirically. Fecal elastase, I think it has some utility, honestly, but I think it's more symptomatic, like what symptoms they're having and everything, and you can see a change. And honestly, if it doesn't work, then it doesn't work. If they don't feel well, then we can always back off. But I definitely do talk to them, try to figure out about if they have signs, symptoms of pancreatic insufficiency, and try to get them on pancreatic enzymes. So in MD Anderson, obviously, we're lucky to have nutritionists who really work closely with us, closely with the patient to optimize these pancreatic enzymes. But either way, you should definitely try them. It's definitely something that can really change the patient's symptoms, and their quality of life can be really greatly improved by pancreatic enzymes.
And just one more note on that is that I'll work closely with the nutritionist to titrate them. Sometimes we'll start someone in, 48,000, units of Creon or whatever brand you want to use, and you realize like they're not getting that much relief for a little bit. I mean, sometimes you just have to titrate them. So it's not just that they might not get immediate relief, or maybe they have mild relief, but you really might be underdosing them too. So it's hard to overdose on the pancreatic enzymes, right? So I have also a low threshold to kind of go up on the dose and work with the patients. Well, good. So one other thing I do want to mention in the palliative care space is attacking the biology of cancer cachexia. So there's been a lot of interest recently in trying to treat cancer cachexia itself, and one of the diseases most prominently we see it is pancreatic cancer.
Yes.
So there's a recent New England Journal paper looking at an inhibitor of GDF15, which is something I never heard of until the study was done. But they looked at weight gain, and actually weight gain was pretty dramatically improved patients receiving an antibody GDF15. So I know we're looking at clinical trials where we're combining that with chemotherapy to say, hey, can we improve, hopefully at a minimum, quality of life, but potentially even quantity, right? If you can help and fix some of the cachexia problem, I do think that could very well translate into improved survival for our patients as well.
No, you're exactly right, John. I think cachexia is a big issue with our pancreatic cancer patients. And really, working on it with these kind of antibodies or other therapeutics and everything can really help the patient, because that's one thing we hear from patients all the time. I'm losing weight, I'm losing lean body mass. They look very different than they used to look. I have patients who show me pictures like 6 months ago, Dr. Pant, look how I looked 6 months ago, and it's just dramatically different. And it's truly, it's sad, honestly, to see that kind of their, somebody who's just, very different from what they were 6 months ago. And if you can, do something to kind of make them whole in a way to at least decrease so they can kind of enjoy and have some weight gain, I think that would really help. So I'm excited about the future. I think if you treat pancreatic cancer, you always have to be a glass half kind of person. So, and that's true. But I think truly there is, because with all the RAS inhibitors that we're testing, this anti-cachexia agent, like I told you about the MTAP deletion, there are a few trials which are running right now in phase 1 and coming to phase 3 in these agents. So I'm very hopeful for the future. And it's not that I'm like super wishy-washy. It's based on hard data, right? It's based on some trials that we are seeing I'm very hopeful for the future. So let's see I'm excited for the next 3 to 5 years, what they bring.
Yeah, we'll have to circle back in a year and we might be smiling a little bit bigger because we have more to offer our patients. Before we close, I want to just briefly touch on not necessarily the gaps that exist in treatment. I think we know what those are. But in terms of providing optimal care really in every setting where patients might get their care. So there are some disparities that exist. I think, you can't speak about healthcare in the United States without talking about that. There are geographic disparities. There are socioeconomic disparities. A lot of these are intertwined. And then, there's what I think is a big issue is access to clinical trials, right? So, I know you're at the mecca of clinical trial activity and you have involvement in everywhere from phase 1 to phase 3. But for most patients with pancreatic cancer in the country, let alone the rest of the world, there's really not that access, right? It's not geographically or financially feasible for most patients. I'm not expecting you to have an answer to this problem, but I didn't know if you had any thoughts on, are there things that you see that can streamline either access to trials, access to optimal care, or things that you see some innovative companies doing where we can really kind of equalize the playing field and get more of our potential exciting treatments to more patients?
Yeah, thanks for leaving the easy question to the end, John. So, so I think you're right. Now, in all seriousness, this is something that we need to tackle. I think having partnerships like MD Anderson has, let's say with Ochsner, I think that's very important and that's critical because really, we really want the patients to be treated near where they are, where they live. Because I think the other important thing is you want to get treated closer to where you are, which is very, very important because you have your family there, you have your friends there, you have your social support there, your caregivers there. So that's really important. And I think that's a critical piece. But there are, nowadays we're looking at decentralized versions of clinical trials, kind of faster, kind of opening in these smaller areas where really critical need is there. So I don't think I have a great answer for you except that, we are trying, honestly, to try to really get these trials out to, community practices that are seeing the patients, that are seeing a diverse group of patients that we might not see in tertiary care centers, where we mostly see more of a younger crowd, maybe with a higher socioeconomic strata. So I think it's really important to have partnerships like we do, like MD Anderson, Houston, MD Anderson, Ochsner have, to really get those trials, closer to where patients are and where they're being treated so they can stay closer to home, closer to their loved ones and not have to travel a long distance to access these clinical trials. So that's the hope for the future.
Yeah, absolutely. I think, what I always emphasize when I'm asked that question, again, I don't expect anyone to have the answer, is just as much as we can decentralize, the better, and make it really patient-centered rather than institution-centered, minimizing pharmacokinetic draws, PK draws, and stuff that needs to be done at a certain institution, whereas they could be done virtually or at home, lab draws elsewhere. I think all of that makes a big difference in the long run. So before we close off here, I just first want to say thank you. I enjoyed this chat, and hopefully our listeners will get somewhat of an overview and somewhat of a recap, but also thinking about what the future may hold for our patients with pancreatic cancer. A few things I just want to recap and highlight is just the importance of molecular profiling, NGS, and germline, as you astutely alluded to earlier, that really all our patients should be getting germline testing. That'll help potentially personalize our therapies, and then also really tailoring our therapies to the individual patient based on their comorbidities, performance status, et cetera. Talking about getting early supportive care, palliative care involvement in our patients who tend to have a lot of high burden of disease and symptoms of whether it's pain or cachexia, malnutrition. And I know you made an excellent plug for pancreatic enzymes, and that really, I mean, it can go a long way in patients' quality of life. I think you hit the nail on the head there. And then keeping the field moving forward and trying to get patients enrolled in trials. There's a lot of momentum in terms of finding new ways to target their proteins and mutations that we didn't think were targetable. Obviously, KRAS being the most exciting. Anything else you want to highlight as a takeaway for our conversation, or?
No, John, all I can say is I'm extremely proud to have you as one of my mentees. This was a great discussion. I think you covered everything. And this is a super comprehensive discussion, very comprehensive discussion about pancreatic cancer. So I think our listeners should, will be pancreatic cancer experts once they listen to this podcast, is what I'm hoping for. So, no, thank you so much, John. This was truly an honor, and it was a lot of fun.
All right. Thank you. I agree. And we'll spend another episode talking about management of early stage pancreatic cancer. But that's it for now. And thanks for listening.
Thank you.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe DeGrazio,
Josh Spencer, and Jaden White.
Design and digital marketing led by Brian Schmitz.
social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.